fully evidence-based approach to evaluating a patient who is struggling to breathe. Now, if you've spent literally any time in an ED or a primary care clinic, you know the exact scenario, right? A patient arrives, they're visibly distressed, just grasping for air. It's a high-stakes moment. So today, we are going to break down exactly how to manage it, moving from clinical basics all the way to some really cutting-edge point-of-care diagnostics.
Okay, let's dive straight into this diagnostic mystery. When your patient presents with acute dyspnea, making the right call quickly is, quite literally, a matter of life and death. Did you know medical databases list nearly 500 distinct causes for shortness of breath? I mean, 500! From the common culprits like asthma and pneumonia to super obscure neuromuscular diseases. Sifting through all that noise and doing it efficiently, well, that is the true art and science of clinical triage.
So here's our agenda for today's explainer. We'll cover Section 1, Understanding Dyspnea and Pathophysiology, Section 2, Acute versus Chronic Causes, Section 3, Bedside History and Examination, Section 4, the Emerald US Protocol, and finally, Section 5, Management and Treatment Options. Let's get into it.
Starting off with Section 1, Understanding Dyspnea and Pathophysiology. So before you rush to order labs or even reach for your stethoscope, we have to remember one absolutely crucial thing. Dyspnea is highly subjective. As defined by the American Thoracic Society, it encompasses qualitatively distinct sensations. One patient might describe a tight chest, another feels like their respiratory muscles are doing a marathon, and someone else might just feel this intense, overwhelming air hunger. It's not just a low oxygen sat number on a monitor, you know? It's a deeply uncomfortable and honestly, sometimes terrifying awareness of not being able to breathe.
But why does that terrible sensation actually happen? Well, dyspnea usually occurs when there's a fundamental disconnect in the body. Think of it like this. Your brain's afferent signals, the ones monitoring blood gas levels and demanding ventilation, are basically screaming for air. But your efferent signals, the actual physical output of your respiratory muscles, like the diaphragm, simply cannot meet that demand. So, whether it's stiff lungs, obstructed airways, or a failing heart, that massive mismatch between neurological demand and physical performance, that's exactly what triggers the sensation of dyspnea.
Moving right along to Section 2, Acute versus Chronic Causes. By splitting these up, you can clearly delineate between sudden, life-threatening physiological changes and progressively worsening structural conditions. If the onset is acute, like we're talking minutes or hours here, you must immediately think of things like a pulmonary embolism, a sudden pneumothorax, or even a myocardial infarction. But if the onset is chronic and gradual, you're much more likely looking at long-term battles, COPD, congestive heart failure, or interstitial lung disease. The tempo of the onset, that is your very first major clue.
Which brings us to Section 3, Bedside History and Examination.
Now, what's really interesting here is the MRC breathlessness scale. It gives us a super concrete, practical tool to actually quantify the severity of the patient's symptoms, based entirely on their daily activities. Dyspnea is subjective, for sure, but this table lets us standardize it. So if a patient is at grade 1, they only struggle during strenuous exercise. But if they're sitting at grade 5, they're too breathless to even get dressed. That immediately tells you just how significantly the underlying pathology is eating into their functional reserve.
But listen, before you even ask about their daily walking habits, you must immediately look for these red flags. If you see hypotension, an altered mental status, hypoxemia, stridor, central cyanosis, absent breath sounds, or unilateral tracheal deviation, which, by the way, screams tension pneumothorax, you stop taking the history. Stop right there. These signs require emergency intervention immediately before you proceed with any further diagnostic puzzle solving.
But here's the real problem. Let's say your patient is stable enough to evaluate, and you do your standard clinical examination. Relying solely on your stethoscope and history to distinguish between acute heart failure, pneumonia, and COPD achieves only about 70% diagnostic accuracy. Actually, let's flip that. It means standard clinical assessment gets it wrong 30% of the time. That leads to inappropriate treatments, longer stays, and way higher mortality, especially in older patients. We absolutely need a better tool.
And that brings us to Section 4, the Emerald US Protocol. This protocol was developed precisely to address that 70% accuracy limitation. It provides a rapid, visually driven flowchart to triage your dyspneic patients safely and effectively right there at the bedside. Instead of waiting hours for lab work or a CT scan, you run this sequential ultrasound protocol. By hunting for specific sonographic signs, like consolidation, B-lines, and lung sliding, you can confidently rule in or rule out pneumonia, acute decompensated heart failure, or a COPD exacerbation in just a matter of minutes. It's a total game changer. So, let's look at how this works.
The protocol requires a comprehensive, targeted search across 4 distinct anterior lung zones on each side of the chest, so 8 zones total. You're looking specifically for B lines, which kind of look like vertical laser beams and indicate fluid in the lung tissue, often a classic sign of heart failure. Or you're hunting for consolidation signs that point toward pneumonia. This structured mapping makes sure absolutely no critical area is missed.
Executing this requires 4 highly systematic steps. First, you check those anterior lung zones for B lines and lung sliding. Second, you drop the probe down to the heart for a 4-chamber view, hunting for a dilated right ventricle, which is a massive red flag for a pulmonary embolism. Third, you compress the veins in the legs to check for deep vein thrombosis, pairing that with your PE check. And finally, you evaluate the posterior lungs for fluid or the dreaded lung point of a pneumothorax. It flows so seamlessly: lungs, heart, legs, and back up.
Finally, let's wrap up with Section 5, Management and Treatment Options.
When we look at our treatment toolkit, we obviously always want to target the root cause. So antibiotics for pneumonia, bronchodilators for asthma, you get the idea. Supplemental oxygen is vital, but a quick reminder, it's actually only effective if the patient is truly hypoxic. For advanced untreatable dyspnea, palliative systemic opioids are incredibly effective at relieving distress. But here's a really surprising fact. Simple, non-pharmacological interventions, like just directing a handheld fan at the patient's face, can significantly relieve breathlessness. Current evidence suggests that cool air stimulates the trigeminal nerve, literally tricking the brain into feeling relief. How cool is that?
Now, before we conclude, we definitely have to acknowledge that breathlessness can sometimes be purely psychological. Have you ever had a patient complaining of shortness of breath where literally every single scan and test comes back perfectly normal? Well, they might be experiencing sigh syndrome. This shows up as recurrent attempts to take a deep breath because of a feeling that they just can't get enough air, followed by a prolonged, audible sigh. It's heavily linked to anxiety. And while it is incredibly distressing for the patient, to them it feels very real, it is physiologically non-dangerous.
So, ending on this thought, dyspnea is one of the most common yet complex presentations in all of medicine. But as we shift away from that 70% accurate clinical bedside guesswork and move toward high-precision visual evidence like the Emerald US protocol, we are completely transforming patient care. It really makes you wonder, doesn't it? As handheld ultrasound devices become as common as a stethoscope around our necks, what other medical mysteries will point-of-care diagnostics help us solve next? Thanks so much for joining me for this explainer, and I hope this approach empowers your clinical reasoning the next time a breathless patient walks through your doors.